Thank you so much. Great to be here. Thank you for inviting me. And I do see fetal patients. I do see adult patients. We started our officially adult congenital heart disease clinic in 2008. Two pediatric cardiologists and two adult cardiologists who are interested in adult congenital heart disease got together and started the clinic. I'm, of course, a little bit advantageous in this part because I can see a pregnant lady there who needs to have a fetal echocardiogram, and then I can actually see the baby, then I can follow the baby. So it's a very good, you can actually take it from fetus to adulthood. I am one of the fetal cardiologists at UT Health, and I will talk about where it all begins, congenital heart disease. So cardiac abnormality, if it is suspected on any obstetric scan, that's one of the indications. We have certain indications, American Heart Association, American Society of Echocardiogram, and ACC, American College of Cardiology. They come up with guidelines. I'm sure you all are aware of those. And some of the guidelines also give us indications when certain studies should be done. And fetal echocardiogram is a very non-invasive study. It's an ultrasound that we do on the pregnant mom to see the baby's heart. Family history of congenital heart disease in a first-degree relative is very important. So if you have a relative or if you have it, and some of the past congenital heart disease patients who have been repaired and are allowed to get pregnant, they are in this category that they should have a fetal echocardiogram. Sometimes persistent arrhythmia in a baby, it could be related to congenital heart disease or chromosomal abnormalities. We know that chromosomal abnormalities, genetic diseases, they do have higher incidence of congenital heart disease. Trisomy 21, Down syndrome 1813, or any of the deletions, DiGeorge syndrome. So they have a high incidence of congenital heart disease. Those are the patients that we would like to see also if it is suspected on the OB exam. Also suspicious level 1 scan. Usually the obstetricians do a level 1 scan. If there is anything suspected there, then these patients are elevated to a higher level care, and then we end up doing the cardiac scans. It could be actually other systems involved. Omphalocele, the abdomen contents could be out, or diaphragmatic hernia. The abdomen contents could be in the chest, which actually pushes the lung, which causes the heart to be on the right side. TE fistulae, or some of the two-vessel cord, or hydrops, fluid collection. It could be collected inside the fetus's abdomen, around the lungs or the skin. These patients, 25% of them have a cardiac etiology, 1/4, very high. There are maternal diseases associated with cardiac abnormalities. So the mom doesn't need to have congenital heart disease, but if they have diabetes, they have association. If they have lupus or any of the collagen vascular abnormalities, or they can have exposure to teratogens or viruses, parvovirus, rubella, Coxsackie virus, alcohol, or warfarin. And some of the adult congenital heart disease patients are on Coumadin, so that's a very important drug that we are very careful monitoring. So what's the rationale for fetal echo? About 90% of infants born with congenital heart disease have no risk factors. So they don't actually have a family history, they don't have any exposure to anything, and it has happened. And it's very difficult for me to talk to the mom why it happened, because it's always the mom trying to find a reason. Well, I didn't take my prenatal vitamins. I just had a glass of wine. Those are not related. And we'll talk about the embryology also. Sometimes it happens, and we don't know the results for most of them. It's the most common major congenital anomaly. It carries a high mortality and morbidity if it is not diagnosed early, and it is reliably detectable in a fetus when an echocardiogram is done in a center. So also with genetics, ventricular septal defects, up to 48% of some of the genetic syndromes have ventricular septal defects. Atrioventricular canal, hole in the upper part of the heart, hole in the lower part of the heart, and one valve opening. Coarctation, narrowing of aorta, tetralogy of Fallot, mitral atresia, Or truncus, just one vessel coming out rather than two vessels. Double outlet right ventricle. Or hypoplastic left heart syndrome, one part of the heart is not grown. Or tricuspid atresia, the valve on the right side has not grown. What's the timing? The fetal heart is fully developed usually by 8 weeks of gestation. We prefer about 18, 24, but we're actually pulling it back because our ultrasound systems are very good. And also, sometimes these parents want to think about what to do with the fetus if it's a very, very significant heart disease. So there are certain limits of termination in some of the states, and Texas is 21/6/7. So if the parents are thinking about that, so we really need to do it earlier so they can actually think about what they want to do with the pregnancy. So 18 to 19 weeks, and we can even pull it back to 16 weeks if there is a concern. Transvaginal probe could be used. As pediatric cardiologists, fetal cardiologists, we do not use it. The OB people use it, and if they have a suspicion, we can always do the transthoracic, transabdominal. And visualization may be suboptimal during the late third trimester. As you know, the baby gets bigger, it gets a lot of cartilage, and so we may not be able to see it really well, but usually we have a diagnosis that will warrant if this baby needs to deliver in a center where you have pediatric cardiology and cardiac surgery availability. Okay, so evolution to revolution. This is a very busy, but I just want to tell you where it all starts actually. The development begins and lasts for about 8 weeks. It begins in the first few weeks of life, the third week, and as you can see here, starts, and then around 8 weeks when the semilunar valves developed, 8 to 9 weeks, everything has developed. Doesn't mean it's not going to progress, but most of the things that are going to happen has already happened at that time. But the disease might actually progress to a worse state. So this is actually the initial heart. It appears in middle of the third week. It's the first major system to develop and function fully. But then the baby really needs more nutrients. So we have a tube. That's the formation of the heart tube. So the heart starts as a tube. And then the fusion begins. First cranially in the third week, and caudal regions actually merge. Then heart becomes a continuous expanded tube. As you see, it's symmetrical here. Starts at symmetrical tube, receives venous drainage caudal pole, and pumps blood out of the first aortic arch to dorsal aorta at the cranial pole. And you're seeing it on the side. And that's the looping. That's why some people have the heart on the right side, some people have it on the left side. The cephalic portion bends ventrally, caudally, and to the right, and the atrial portion actually shifts dorsocranially and to the left. This bending, which may be due to cell shape changes, creates the cardiac loop, which usually is complete by day 28. Because there is not enough space, it has to bend. Here, this is the primitive right ventricle, primitive left ventricle, atrium, and then the aortic arches. As you can see from the side, if it loops one side, you're going to see on the left, and if it's going to loop on the other side, the ventricles will be looped on the other side. So that's actually the cause on some of the cardiac diseases. So if it is looping in the right way, future right ventricle, future left ventricle, future right atrium, and future left atrium. And that's the truncus arterius, which gives rise to the two vessels. So fourth week, the systemic veins, the superior vena cava, inferior vena cava, the ones that bring the mixed venous blood or the blue blood, unoxygenated blood, developed. About the fifth, seventh week, atrial and ventricular septum, the walls in between the upper and the lower chambers, they develop. About the 9th and 10th week, the aortic and the pulmonary valves also develop. As you can see, the septation of the cardiac outflow, and it septates, and you have an aorta and pulmonary. It doesn't septate, you're going to have truncus, just one vessel there. So when everything develops correctly, what do we see? I'm sure most of you know this by heart, the right side, right atrium, right ventricle, left ventricle, the upper and lower chambers, the walls in between, superior, inferior vena cava, and the blood goes unoxygenated to the lungs, gets the oxygen, comes back to the left side, and then goes to the aorta. In a fetus, it's a little bit different. Fetal lungs are not expanded. They don't do the oxygen exchange. Where does the oxygen exchange occur? It occurs actually through the mom, through the placenta. So the more oxygenated blood actually comes from the lower side, the inferior vena cava, and comes to the heart. And you want that oxygenated blood to go to the aorta, the head and neck vessels, and your coronaries. So it passes through a small hole, the foramen ovale, that's a flap, from the right atrium to the left side, and from there goes directly to the aorta. Some part of that blood comes to the right ventricle, goes to the lung vessel, but there's also another connection in between the lung vessel and the aorta here that's called the ductus arteriosus. And some part of it bypasses the lung and go directly to the aorta also. So you have the oxygenated blood going to the aorta directly from there. So this is the fetal physiology. And as long as the fetus is inside the mom, even with really significant congenital heart defects, they do okay. So we tell parents, don't worry about it, go full term, and most of the time normal delivery is okay. We don't really advocate, unless there is a OB reason for it, C-section. So as long as the fetus is inside with the fetal physiology, most of those even the very significant heart disease fetuses, they do okay. So when we do a fetal echocardiogram, what do we look at? We look at the stomach because it's important. Sometimes stomach could be on the other side. With very significant heart diseases, the abdominal contents could be actually different ways. The liver could be on the left side, the heart could be on the right side. That's a site. So we have to identify the positions. And the more significant the heart diseases are, the more you're going to see these. We look at the heart size. We also look at the axis, where it is pointing. Usually in the fetus, when you look at the heart, it's about 45 degrees angle. But if it is not 45 degrees angle, if it is angled differently, that also is a suggestion of there could be other cardiac diseases in these patients. We look at the intracardiac connections. The atria connecting to the left to the ventricles, are they connecting to the right ventricles? We're looking at the arterial connections. Are the vessels coming out from the normal connected ventricles? If the pulmonary artery is coming from the right ventricle and if the aorta is coming from the left ventricle. So we look at those connections. We look at the connections in between. We look at the foramen ovale, the ductus or VSTs. We look at all these connections. So when we do that, we actually get a picture. This is upside down, but we can tell the baby to turn this way, so we get what we want. And the baby really doesn't listen to us, so whatever they show us, we're happy with that. So this is the left side is actually the left ventricle, left atrium, RV, and RA. So this is a good four-chambered, very well-developed heart. We do some fetal views, the basic views. We look at the four-chamber heart. We want to see all these chambers have developed okay. We also want to see the left ventricular outflow tract. We want to see if the aortic valve has grown okay. We want to see the right ventricular outflow tract. We want to see if the right ventricular outflow tract and the pulmonary valve has developed okay. We want to see the arches. We want to see the aorta if it has developed okay. We want to see the ductal arch, which is very important, as you have seen there. The ductus that connects the pulmonary artery and the aorta. That's also very important anatomic finding that we look at. We look at all these systemic veins. We look at the pulmonary veins that bring the blood backwards. We also look at everything with a 2D, what we call, the grayscale, and we look at it with color and also Doppler. We look at certain velocities. We look at where the flow is going from one side to the other side. So this is a fetal heart. It looks big. It is not that big. So this is the fetal heart. I tried to make it bigger for you. And so this is actually the aorta. You can see the left side of the fetus. This is the left ventricle, right atrium, and left atrium. You can see the flap of the foramen ovale. This is going to be allowing the blood to pass from the right atrium to the left atrium. This is a very good heart, a normal scan. We're happy. And we look at color with this scan. We want to see where this blood is going from. And as we know, if you look at this is like a triangle, the blood that's going towards the tip of the triangle is going to be red, and that's going away from it is going to be blue. So we can actually see and predict from where to where the blood is going to. So this is the left side of the heart, the aorta, as we said, and this is a cephalic presentation. And the septum, you don't see anything crossing here, so there is no problem VSD. You see actually something crossing here, the PFO, and from where should the blood go? From right atrium to right ventricle. You see the blue blood going there. So everything is actually connected normally and the blood flowing normally. We also want to see if those vessels are crossing each other. Aorta, and as I have shown you after the looping, when the aorta and the pulmonary artery they twirl around each other, they actually make a cross. So this is the one that you're seeing here is the pulmonary artery. As you can see, the branches very nicely, and then the other one coming here is going to be the aorta. So they're crossing. It is a normally related great artery. So this fetus arteries are normally related. Here again, this is going to be your pulmonary artery, and then the aorta is starting to be seen here. We want to see the arches, the aortic arch, very nicely. We can even see the head and neck vessels there, connections going to the head. And we see some of the systemic veins coming. This is the IVC coming. We see a little bit of the SVC coming here. So we look at all these. If there's coarctation, sometimes we can actually see narrowing here. And you can see it's wide open. We look at the color. If the color actually is not laminar, that gives us an idea that there might be some narrowing there. So all of these little things we look at in the fetus. So when we look at the four-chamber, we can actually see a lot of the heart diseases, like an AV canal, the atrioventricular canal, or VSDs, the holes, or if the valves between the upper and the lower sides are not working well, or large VSDs, tricuspid atresia, hypoplastic left heart. But sometimes we can actually see it normal in patients who have, the vessels have actually coming abnormally from different ventricles, or if there are small VSDs or small ASD, or if there is a valve abnormality. We may not be able to see it on a four-chamber. That's what we have to look at on different views. And this is actually, I'm sure you're going to be appreciating it, the left side and the right side, the indiscrepancy in between. This is a hypoplastic left heart syndrome. The left side is small. I have another baby here. I didn't want to bring a lot of abnormals, so I just wanted to look at the normal. This is an AV canal. You can see there is actually a dropout here, and that is the hole, and then another dropout on the upper part there also. Also abnormal arches, as you can see how narrow this is here. That's your coarctation, and a narrow aortic arch. Difficult to diagnose sometimes, but if it is this narrow, we will be able to see it. You see here, there's something abnormal. We can actually diagnose cardiac tumors. This is a patient with tuberous sclerosis and who has a rhabdomyoma, which is a benign tumor, though it looks really big here. So we make measurements on the arteries, dimensions, and compare it to the patient's, the fetus's age. And we also look at velocities, we look at the Dopplers, and we look at also arrhythmias. Sometimes we can actually see the arrhythmias and where it is coming from. It's coming from the lower side or the upper side. Some of these arrhythmias are related to congenital heart disease, not all of them, but some of them actually are related to, like Epstein's might be causing arrhythmias, or patients with corrected transposition, the ventricles are inverted. Those patients also might have some low heart rate, so that's the bradyarrhythmia. And we can do different studies to actually look at if the atrium and the ventricle are causing, every atrial kick is causing a ventricular kick here. Sometimes you don't see it, so that's actually a blocked rhythm here. So we can look at a lot of things. So this is a fetus that had I don't know why it's not playing well. It was an arrhythmia. It was supposed to be very, very fast. Like, okay, now it's picking up. So this is an SVT, and that actually is a. Is it playing there? Not yet. Here, the heart cannot really squeeze the blood out. So this is very important. So, fetal echocardiography, anomalies are present, approximately 10% of the fetuses selectively referred for fetal echo. Both false positive and false negative diagnoses of cardiac anomalies might occur, but the false positives could be like coarctation. Sometimes we might not actually see some of the things, but those are really very minor things that we would not really be worried about that much. But lesions difficult to detect could be the small size VSDs, coarctation, minor abnormalities, ductuses, and ASDs. Some lesions could be progressive, as I said, that the heart develops 9 weeks of life, but pulmonary stenosis or it could be a hypoplastic left heart that develops from an aortic stenosis, mitral stenosis, and then you do actually see them in 6-8 weeks later. You see like the left side has become very small. So we always say like if there's not much flow, it's not going to grow. So you actually can see that progression. So a normal early fetal echo does not guarantee a normal heart. So if your OB is suspecting something later on, we would like to see that baby again. So, fetal echo is not perfect, but results depend on many factors: operator experience, timing of the study. In experienced centers, the diagnosis is close to 100%. Technical difficulties, of course, we do have certain technical difficulties, obesity in the mom. If the fluid is not much, abdominal scarring might really cause, but we try to overcome it with better system ultrasound machines. So if you actually diagnose the patient that is ductal dependent, that means that the baby is not going to survive if you don't keep that ductus open until surgery, then that is important because those babies should be delivered in a center where you have pediatric cardiology and cardiovascular surgery. So we don't want to miss any of those babies. And there are non-ductal dependent simple lesions. And we can always tell the OB, that's fine, they can deliver with their OB in a center where we don't need to have cardiovascular surgery, but we need to follow them in the pediatric cardiology clinic. So, prenatal counseling, we do it. It will depend on diagnosis, security of diagnosis, gestational age, associated extracardiac abnormalities, natural history, and surgical options and results. So, last slide. So you have to go to a place where there is multidisciplinary approach. We do have it in the fetal center at UT, Children's Memorial Hermann Hospital. We have maternal fetal medicine specialists, high-risk OBs who take care of the mom, maternal fetal medicine specialists who take care of the fetus, fetal pediatric cardiologists, we also take care of the patient, the fetus, geneticists. The mom wants to talk to the geneticist, wants to know what's going to happen in the next babies or with the other siblings of this baby. Cardiovascular surgeons. Our surgeons come and talk to the parents and give them the percentages, what to expect. Interventional cardiologists. Some of these actual fetuses may need intervention, not surgery afterwards. Neonatal intensive care specialists. They come and talk to the patient and say, what's going to happen? The patients actually go and visit the post-op unit and intensive care unit, and they are familiar with it. Once they deliver, where is their baby going to go? And after surgery, where is the baby going to be? So it actually really prepares the parents to what will happen after the baby is born. Neurosurgeons and other pediatric subspecialists. So it is a one-step, one-stop place that these parents will go. Thank you so much.